Okay, thank you for joining this third webinar arranged by the ERA-EDTA on COVID-19. And today we're focusing on registry data from the Spanish registry and the newly formed European registry, ERA-CODA. My name is Kate Stevens. I'm a nephrologist from the UK and I'll be moderating today. So just very briefly, some housekeeping. Could you make sure your microphone is on mute when other people are talking? We're very happy for this to be interactive. So you can either use the raise your hand function or you can type into the Q&A function to address the panelists. And you're most welcome at any point to pass comments which are relevant to the discussion. So I'm delighted to introduce our panel today. It's very kind of them in the midst of everything that's happening clinically that they're able to come and join us. We have Professor Emilio Sanchez from Spain, Prof. Luc Hilbrandts and Prof. Ron Gansevoort, who are both from the Netherlands, and we have Prof. Christoph Banner from Germany. So without further ado, I have one more thing to tell you. The sessions are recorded and are available on YouTube and our ERA website, so they can be watched back, or your colleagues who haven't been able to join us can watch them. And we'll get started with Prof. Emilio Sanchez, who has data to present from the Spanish registry. Thank you very much.
Thank you very much. First of all, I want to thank the organizers for having invited me and also the Spanish Society of Nephrology to this webinar. And I also want to thank all my colleagues here in Spain, nephrologists that are working under very bad conditions nowadays, but they found some minutes to register their patients in our database. So to all them, thank you. During the next 12 minutes, I will talk about the COVID-19 registry of the Spanish Society of Nephrology. Next slide, please.
Yes, just a second. Okay.
Okay, so it hasn't moved, Francesca. I think it's read only. You need to change it to, yeah.
Yes, okay, thank you very much. As all you know, at the end of 2019, the Chinese authorities report to the World Health Organization several cases of pneumonia of unknown etiology in Wuhan. Later, it was found that it was an infection caused by a new coronavirus called SARS-CoV-2. Since then, the virus has been spreading throughout the world, reaching to date almost 2 million people. Next slide, please.
Yeah, just a second. I have to, sorry. Just a second.
The first case in Spain was in the island called La Gomera in Canary Islands. There, the case was registered in January the 31st. A German tourist that had a known prior contact with infected patients was the first case reported in Spain. Next slide, please.
Just a second.
Since then, many things have happened, and nowadays, and these are data from yesterday, from April the 15th, there are more than 175,000 cases registered in Spain, near 1 million in Europe, and near 2 million in the world. Next slide, please. Okay, that's good. In this slide, you can see the evolution of the number of cases, deaths, and recovered patients in Spain. Our problem began from March the 8th with an exponential increase in the number of infected patients. Unfortunately, in the last weeks, we have reduced the number of new cases. The biggest cities And those regions with highest number of population has the biggest number of patients infected with COVID-19. Next slide, please. In the next slide, you can see the evolution of the new cases by dates. And as you can see in the image, since the 1st of April, the new cases has been going down, and also death people is going down. Till here are data of the general Spanish population. Next slide, please. And the final image I want to show you in my introduction is a picture of the renal replacement therapies in Spain. These are the data of our registry, the registry of renal patients at the end of the year 2018. As you can see, more than 60,000 people in Spain are under renal replacement therapy, but unfortunately, more than half, around 55%, are transplanted. We are one of the world's countries with the biggest number of transplant patients. Next slide. I want to show you now some key data about the COVID-19 registry in Spain. The first data is March the 8th. That day, the Spanish Society of Nephrology decided to create the registry. Next slide, please. And in only 10 days, the 18th, the registry starts working. In those days, an experts committee and some computers, men and women, worked to create the registry. We published the first newsletter in March, at the end of March, the second newsletter in April the 4th, and finally, next slide please, the third newsletter in April the 11th. Next slide please. And now, today, the 16th of April, we are in this webinar. Next slide please. The COVID-19 registry of the Spanish Society of Nephrology has an online format with access through the Society's website. Prior identification is necessary. Each user of the registry has access to the patient's data they have entered, but not to the rest of the information. Next slide, please. This is the registry's database. Epidemiological variables, modalities of renal replacement therapy, data about infection and diagnosis, clinical features. Next slide, please. Data related with treatments and the outcome were included in the registry. Next slide, please. These are the number of patients included in any newsletter. We published the first newsletter with near 200 patients, the second newsletter with 600 patients, and finally the third newsletter with 868 patients. But today, we are today in April the 16th, we have more than 1,000 patients registered. Next slide, please. Today I presented data of the first 868 patients on renal replacement therapy in Spain who have been infected with COVID-19. Patients come from 103 health centers distributed throughout the country. By regions, Madrid registered the highest number of cases, around 36%, followed by Catalonia, 18%, and Castilla-La Mancha, 12%. As you can see in the Spanish map, the number of cases in renal replacement therapy patients are distributed in the same way as in the general population in Spain. The next slide, please. About epidemiological data, I want to say that the average age of the infected patient is 67 years old and 2/3 are male. These data are similar to those reported by the Spanish Registry of Renal Patients. Next slide, please. The most represented form of renal replacement therapy among patients with SARS-CoV-2 infection was in-center hemodialysis, more than 60%, followed by transplant patients, 33%, and much less frequently, those who are on peritoneal dialysis, and only 2 cases have been reported in home hemodialysis. Despite the fact that more than half of the Spanish patients on renal replacement therapies are transplanted, there are more SARS-CoV-2 infected patients who perform in-center hemodialysis. This circumstance is not surprising when dealing with patients who have not been able to do the regulatory confinement due to having to go out and travel to hospitals in dialysis centers 3 or more times a week and not infrequently on public transport. In addition, not a few patients who perform in-center hemodialysis live in nursing homes, epicenter of many infections. Despite the degree of immunosuppression of transplant patients, they only represent 1/3 of the registered patients. Finally, it should be noted that patients on peritoneal dialysis, and especially those on home hemodialysis, represent a very low rate of infected patients, although their representation as a modality of renal replacement therapy in Spain is also significantly lower. Next slide, please. Around 30% of infected patients had had no prior contact with someone else infected. This percentage rose to 34% in the case of patients on in-center hemodialysis. The average incubation period in those patients registered at prior contact was around 1 week. Next slide, please. In relation with clinical features, 3 out of 4 patients had fever, 2/3 symptoms of upper respiratory infection, and 43 dyspnea. Only 8% were symptomatic at time of diagnosis. Pneumonia developed in almost 75% of patients, and lymphopenia in 80%. Next slide, please. 85% of registered patients required hospital admission, 8% being in intensive care units. 2/3 of the patients admitted in these units require mechanic ventilation. Next slide, please. The most commonly used treatments were hydroxychloroquine in 85% of patients and lopinavir-ritonavir combination in 40% of them. 1/3 of the patients received all 3 drugs together. Interferon and tocilizumab were used in a short number of cases, especially in transplant patients. Next slide, please. Dialysis, including in-center hemodialysis, home hemodialysis, and peritoneal dialysis, and transplant populations that have been infected with SARS-CoV-2 are different. In this table, you can see its characteristics. Transplant patients were younger, they needed to be admitted more frequently, they developed more pneumonia and were treated in great number of cases with lopinavir-ritonavir, hydroxychloroquine, steroids, and tocilizumab. They also received more rust before the infection. Finally, fewer transplants died. Next slide, please. To date, near 200 patients have died, around 23% of those registered, and 177 have been reported as recovered. When we compare both groups, recovered and deceased, we verify that deceased were older, were more frequently in-center hemodialysis, developed pneumonia more frequently, and also received lopinavir-ritonavir and steroids and less rash before the infection. Next slide, please. We also analyzed those factors associated with mortality, differentiating transplant patients from those on dialysis. In transplant patients, age and the development of pneumonia were independently associated with mortality. As for the dialysis patient, it was again the age and the development of pneumonia, and also we found a beneficial effect of the use of hydroxychloroquine. Next slide, please. Finally, the cure has been reported in 20% of total infected patients. The average reported time to cure is 12 days. The rest, near 60%, persist in a situation of active infection. Next slide. So I have just presented preliminary data of our registry. Please realize that almost 60% of cases have not yet reached the outcome. So in the coming weeks, we can have much more information. And here are my final messages. SARS-CoV-2 infection is affecting Spain in a major way. Population on renal replacement therapy is suffering significantly from the effect of this pandemic. More than 1,000 patients have been registered in the Spanish Society of Nephrology Registry COVID-19. In center hemodialysis, patients are more affected and have a worse prognosis. Mortality is around 25% in dialysis patients, falling to 19% in transplant recipients. Age and the development of pneumonia have an impact on mortality, and perhaps hydroxychloroquine may also have a beneficial effect in dialysis patients. So far, 20% of patients have been recovered. Next slide. And my final message is this, that today and ever, nowhere better than home, with our data, with our analysis of our data, we can say again that renal replacement therapy at home, and I mean renal transplantation, peritoneal dialysis, and home hemodialysis have a better outcome in this situation. Thank you very much.
Thank you, Prof. Sanchez, that was excellent. So I'd intended actually that we had questions mostly at the end, but there are a couple of questions specifically for you, so if you don't mind, I'll ask you them just now. So John Jin Kim is asking 2 questions about transplant patients. Wondering what the change in immunosuppression was in transplant patients, so how you altered immunosuppression, and whether or not you saw any differences in the rates of rejection on the basis of changes to immunosuppression.
At the moment, we have not data about immunosuppression. We began to record that data later. So today I can say nothing about the evolution of immunosuppression. I only have data about the treatment of SARS-CoV-2 infection. But probably in the next week, we will we can show data about this thing.
Okay, perfect, thank you. We have a question for the ERA-CODA team, but we'll ask that following Prof. Hilbrand's presentation. Prof. Brookfeld, Annette, is asking what dose of hydroxychloroquine you used in the CKD patients, so both dialysis and transplant, and if you have any idea for how long they were treated, so the duration of treatment.
Again, I have not enough data to say that, but as we can see in the patients in my area, they need treatment for more than 2 weeks.
Okay.
But we need more weeks, more days to analyze all this information.
Did you notice from your personal experience any issues in terms of cardiac problems, so long QT, and were you doing ECGs on these patients?
It has been noticed that some problems in that, but we know it and we are aware of that.
Sure. Okay. Thank you very much. So
Thank you.
Can I now ask Prof. Hilbrand to present the ERA-CODA data, and we can have further discussion after he has presented. Thanks very much.
Thank you.
Thanks very much, Kate. Thank you for the invitation. which is mainly based in the Netherlands. And ERACODA stands for ERA-EDTA COVID-19 database of kidney replacement therapy patients. Well, I have structured my presentation along the following format. I will start to tell something about the background, about the formation of a working group. Then I will proceed with telling you something about the design of our database, about the management of the database, some really preliminary results, and I will end with summing up some issues about administrative and regulatory affairs which are involved when you are, which are come in play when you are setting up such a database. Well, of course, the background is clear. There is maybe an impact of COVID-19 on patients with kidney replacement therapy, but how large the impact is currently unknown. We are aware of the fact that dialysis patients have a high burden of risk factors, like a higher age and cardiovascular comorbidity. We also know that kidney transplant patients use immunosuppressive drugs, which can result in a more severe course of COVID-19. And although for these reasons, a more severe course of COVID-19 in dialysis and kidney transplant patients could be expected, there are also some reports that suggest a relatively mild course in these patients. And one theory is that maybe the uremic state or the use of immunosuppressive drugs might prevent the exaggerated immune response, which is often seen in later and more severe phases of COVID-19 pneumonia. So we need actually granular data on an individual patient level to make better prognosis for the patient, to have prognostic information which can support clinical decision making. And we also need to identify risk factors, and especially risk factors which could be modified, like the use of certain drugs, the use of immunosuppression, which we could change upon presentation of a patient with COVID-19. Well, it's only a few weeks ago that the Council of the ERA-EDTA decided to establish an ERA-EDTA-wide database, so for collection of individual patient data in Europe, kidney replacement therapy patients with COVID-19. And there are also existing databases like the ERA-EDTA Registry, which is a regular database for follow-up of kidney patients. But in this database, only a very limited set of data can be collected. So there was really a need for an accompanying database which allowed the collection of a much wider set of data, which would allow us to identify the risk factors and to be able to give more information about the prognosis of these patients. So the working group was formed, and here are the members listed with a picture. Ron Gansevoort, who is a council member of the ERA-EDTA, Casper Fransen, nephrologist in Groningen, the Netherlands, who leads the dialysis subdatabase. I lead the kidney transplant subdatabase. Mark Hemelde is the director of the Dutch National Kidney Replacement Therapy Registry, and Kitty Jager is the director of the ERA-EDTA Registry. And you will notice that that all these people work in the Netherlands. And that was indeed in the first phase of setting up this working group a very convenient feature, because we could be easily in contact with each other and we could progress very fast. We also installed an international advisory board consisting of the chair of the ERA-EDTA Registry, Professor Siad Massi, and also a chair and 2 additional members of the ERA-EDTA working group UDIAL, which is a working group on dialysis, and also a chair and 2 additional members of the ERA-EDTA working group Descartes, which is involved in transplantation. Well, how did we design our database? We collect the data in a certified electronic record system, called the RedCap, which is hosted by the University serve Europe, and we try to answer the most important questions. But on the other hand, we also realized that especially during these times, asking a lot of time from clinicians to complete the records would not be useful. So we tried to limit the amount of time needed for completion. And people who already have completed the database will have noticed that it doesn't take more than 5 to 10 minutes if you have some experience in filling in these data. Well, we added specific questions for kidney transplant and dialysis patients. It's more comfortable when you complete the records when you only have to answer the questions that are appropriate for this patient. So a lot of questions only pop up in certain circumstances. Of course, we collect data about patient characteristics, about COVID-related items, follow-up and outcome, and I will show you which items are especially collected later on. It's important to mention that the data are pseudonymized. They include an identifier of the transplant registry or the National Kidney Replacement Therapy Registry, but no other items or data that can lead to identification of the patient. And another important asset of the database is that the data ownership will remain with the data submitter. So the data submitter can at any time ask for removal of the data from the database. This is an example of a screen which you can see when you enter data to the REDCap system. Well, you see here are some items related to patient characteristics. And here is a screen with outcome parameters. We, for example, collect the date of admission, but also the date of the admission to the ICU, date of intubation, also the date of renal replacement therapy, and also the date when all these treatments are discontinued. It is quite a job to manage such a database, and we are very lucky that we have a very good team of study coordinators, epidemiologists and database managers in Groningen. You see them here, 4 ladies who have worked very hard, very many hours during the past weeks to manage this database. What is included in the management of the database is that there is a check on the completeness of the records so that we can really answer the questions that we want to address and not have information only on some key issues. And we check the records also on duplicates. A very nice outcome of the database already is that we have weekly tabulated reports of the complete data set, and this complete outcome is published on the ERA-EDTA website, and it is also distributed to all the people who participate in the database. And those who have seen these reports can confirm that it's really a complete data set of all the data that have been entered. So not only some highlights, but all the data that are now included in the data set are reported at weekly intervals. Even if there are some missing data, we are very transparent to provide the number of missing data so that all people who participate in the database are encouraged to complete the records to get the missing data as low as possible. And when there are questions about the database, you can always send an email to the email address that is given here, and then you will become in contact with one of the database managers. I told you that the results, the outcome of the database are also posted on the ERA-EDTA website. You can find it here. There's a special entry on the ERA-EDTA website called the ERA-EDTA COVID-19 database. And you also will find some additional information like the mission statement of the database, how the database is structured, how you can register as a user, how you can enter data. But here in the lower part, you can find the data reports, and you can see that they have been uploaded at a weekly base until now. So these are some preliminary results collected until yesterday. We have more than 200 individual users in the system now, coming from 170 centers from 34 European countries. So that's really a large representation from Europe, and I think that's an important feature of this ERA-EDTA database. Until now, 184 patient records have been entered, and I think today maybe some more were entered in addition to that. And the results that I show you now is based on the analysis of the first 134 records. 75% of them kidney transplant patients and 43% dialysis patients. The majority of the patients were male, like in the Spanish database, and here the age is somewhat lower than in the Spanish population I saw just a few minutes ago. Well, I do not show all the characteristics that we have in the database. I'm happy to refer you to the reports that are posted on the ERA-EDTA website. But some of the figures are shown here. The characteristics, for example, body mass index, not that high. In some reports you find that many patients with COVID-19 are obese. Actually, the percentage of obese patients in our database is relatively small. This is just also to show you an example of the symptoms that we collect, and to show you that diarrhea is one of the symptoms that can occur in kidney transplantations, in this case in about 1/3 of the patients. As said, there are many more items in the database, and the use of immunosuppressive drugs and also the changes in the use of immunosuppressive drugs. You can find that in the report. There was a question just a few minutes ago about the reduction of immunosuppression in our patients. In about half of the cases of the patients that were admitted to the hospital, the doses of immunosuppressive drugs were reduced within 48 hours. You can find information on the use of ACE inhibitors and angiotensin receptor blockers and the continuation or the discontinuation of these drugs, the type of antiviral therapy that is used, the type of anti-inflammatory therapy, and also we collect the reasons for any possible withholding of ICU admission or intubation. In some cases, this might be related to limited capacity on ICUs. In other instances, it might be a deliberate wish of the patient or the family not to be transferred to the ICU. Here is a distribution of the patients that are not admitted to the hospital, but not to the ICU, and the patients admitted to the ICU. And in red, you see the proportion of patients that are deceased. So we now have in our kidney transplant population 10 patients, and that's indeed more or less the same percentage as was found in Spain. Between 15 and 20% of the patients died. But again, these are very preliminary findings. We have not completed follow-up in all patients, of course, because it's only a few weeks running now. For the dialysis patients, you see that the proportion of patients that is admitted to the ICU is much smaller, and all the patients that died in this series died outside the ICU. When we started this initiative, our main goal was to collect some information on the treatment of patients in a very fast window, a very short window. We were happy that the ethics committee of the University Medical Center of Groningen waived an approval in the context of the Medical Research Involving Human Subjects Act, because we are only collecting existing patients' data, and the patient has not to undergo additional procedures. But of course, we realize that for use of the data for scientific research, we have to be compliant with the General Data Protection Regulation. And therefore, we now have prepared a lot of documents that are nearly finalized, and that can also be used by people in other hospitals and for use in their hospital. And we will also publish this toolbox of documents on the ERA-EDTA website. Well, I think that there are some main assets of the ERACODA database. It's a relatively large data set on kidney replacement therapy patients with a representation from many European centers. So we are in the end also able to compare the outcome between countries and maybe between centers within countries. I think that the data are sufficiently detailed for a meaningful analysis of risk factors, hopefully modifiable risk factors. I would like to mention that this database is fully driven by healthcare professionals. There are some other databases that you can find on websites in which commercial parties are involved. That's not the case in our database. It's fully driven by healthcare professionals. And one of the major assets is that we can in the future connect our data with that from other European databases, because we have the unique identifier for each patient in our database. So, for example, we can connect the data to the existing ERA-EDTA registry, and also with the Eurotransplant number to the Eurotransplant registry for patients living in the Eurotransplant region. And of course, we would be happy to or data with that of other data sets, for example, the large data set that has just been presented by Emilio Sanchez. Well, I already said that we will proceed with weekly reports of all entered data on the website. In the end, after 3 months, we will also start an additional data collection to guarantee the completeness of all records and to make the most of we can from this database. So I would like to ask your contribution to the ERACODA. I think not for us or for anyone, but especially for the sake of your patients, because only by collecting more information, we can
I think we might have lost Prof. Hilbrands. He'll maybe try to reconnect with us, although I think he was almost at the end of what was an excellent presentation, and makes a very good point that what we really need here is some hard data, so as we can use that information to modify risks and also to guide therapies. So I'd maybe like to open up to Prof. Gansevoort and Prof. Vanner, whilst we see if Prof. Hilbrands can reconnect. Prof. Vanner, particularly, do you have any comments to add from your experience in terms of the German registry?
Not yet. We have no information. We have established this registry. GDPR was an issue. Still, many IRBs have not waived everything, so we haven't got any information so far. Can I have a question to Emilio Sanchez?
Of course you can.
Emilio is on mute, and so Emilio, in Germany, we have no critical situation so far. We had 2 hotspots in dialysis centers, but we are afraid that in the future, when the situation is heating up, the dialysis patients may be triaged. The elderly are in the highest risk group, and our friends from critical care medicine may not take them onto the ventilator. My question is, was this a concern in Spain so far or not yet?
Thank you for your question. Of course, it is a concern. We also have problems, some problems in Spain with moving patients on dialysis to intensive care units, and also for mechanical ventilation. As intensive care units are full of patients, in some hospitals, they prefer to move their younger patients or patients with less health problems as those that we have. In Spain, the age and comorbidity of dialysis patients is high, so many of them will not go to intensive care units. We fight for them, but we not always get an appropriate answer by our colleagues in the intensive care units.
So in the UK, there's been quite a lot of concern about patients not getting into intensive care because they're on dialysis. And the UK Renal Association came out with quite a strong statement saying that they felt patients should not be excluded on the basis of being dialysis patients. And the decision should be made on the basis of whether or not they had multiple morbidities, etc., which might otherwise preclude them. But the difference obviously here, like in Germany, is that we haven't reached a critical situation like we've seen in Spain and in Italy. And I think a lot of our dialysis patients have actually been quite concerned about it. What about in the Netherlands? Do you have any comment, Ron, perhaps, about dialysis patients being excluded from intensive care?
In the Netherlands, we have fortunately still a relatively good situation. There's a hotspot in the southern part of the country, with many patients being admitted to hospital and to intensive care unit, but fortunately we have not reached the limit of our ICU capacity yet. At the same time, I also had a look at the data, and when we're talking about mortality, we are looking already at the mortality in our data sets, and we should be very cautious by interpreting these data because they can be used in a proper way, but also in an improperly way. When we first saw the first data of the Spanish registry, there was a 44% mortality. And it was, of course, very, very alarming. And people could use that as a kind of argument not to admit hemodialysis patients to an intensive care unit. And when I now see the data in Spain, because we've got longer follow-up and a larger set of subjects, mortality has dropped to 25%. And what we see in the ERACODA database is that their mortality is even lower. So it is perfect that we are collecting data at this moment, and these are very important data. They are useful for the future, but we should be very cautious in interpreting these data and already deciding the future of our patients on these data.
Yeah, I think that's a really important point, isn't it? Having the data. Do you have any feel for what the reason for mortality is? So obviously the rate in dialysis patients in the renal population is significantly higher than in the general population, although not as alarming as 44%. So do we think it's frailty, cytokine storm, bacterial infection, or do you think we don't know?
I was looking at the age, and the age in the moment is 59 years in the European database, and it's 69 in Spain. And my question is, in Spain, the younger people get transplanted at a very high rate, and what is remaining in the dialysis patients may be older. So can this be just selection bias for the 59 patients in the moment entered, younger and an older age in Spain?
I agree with you because here in Spain, a lot of patients, younger patients, and patients with short comorbidity are transplanted every year. As I mentioned before, more than half of our patients are transplanted. Patients in central hemodialysis are the worst patients. They are older and with a high comorbidity. As you can see, the age, the median age was around 70 years old. So mortality rates in that range of age is high, even in those who are not under renal replacement therapies. In Spain, general mortality is around 3 to 4% in the general population, but we have this data in renal replacement therapies patients. But be aware that the results are not the same in dialysis when we compare with transplant patients. And also our data today are better than in the first analysis 2 weeks ago. Perhaps there was a bias, and my colleagues only registered the data of the first patients that were those who died at the beginning of the time of the registry. And I think that we must wait 2 or 3 more weeks in order to get more patients achieved the final destiny outcome, to be recovered or to die. At this time, we have more data to show you and more exact data to show the European people.
Thank you. So I see Prof. Hilbrand has rejoined us. Thank you very much for your presentation. We enjoyed it, and we thought you were almost at the end when you got cut off. Do you have a question for Prof. Sanchez?
No, maybe in addition, I think in this discussion about the mortality of dialysis patients, we have to realize that indeed the age of these patients is very high, and they have a high burden of comorbidity, cardiovascular comorbidity. So in fact, we should compare the mortality of the dialysis patients with age-matched control patients and patients with a similar profile to see whether there is an additional risk of dialysis. And that is one of the aims that we have with the European database, that we form a kind of a control group from the ERA-EDTA registry with patients with a similar age, coming from a similar country, maybe with similar primary kidney disease, to see whether there's an added risk of the dialysis state. And the same analysis we will try to make for the transplant population, where we can maybe get a control group from our national kidney transplant registration.
Very good.
So we have a few comments and questions from the participants, the audience. So first of all, actually, the most recent comment was just that in Spain, obviously, there's a higher rate of living donors, which is obviously an important point to make. So let me just go through these. So specifically about the ERA-CODA dialysis population, we have a question asking about the toxicity profile seen in these patients. Now, you might not have this information yet. So it's about medication and treatment. So asking about hydroxychloroquine, we would obviously dose adjust that traditionally if somebody is on dialysis. I don't know if you have that information, Luke or Ron.
No, we don't have that information. So we collected the data on which medication is used, but we have no data on the side effects of these medication. I think there are other databases that can give this information. Of course, also on the ICU department, there are databases that collect several items, but we do not have specific items on that issues in our database.
Yeah, thank you. So there's a question here. So CKD 4 and 5, are they at higher risk? I think the answer to that question is yes. I'm not sure whether you have any data from your databases to support that comment yet. I think we're all in all of our countries seeing that our CKD patients are at higher risk.
Well, actually, we are focusing on patients on kidney replacement therapy, so only patients on dialysis or living with a kidney transplant. And
Emilio, do you have any information about the CKD population?
Our registry is only for patients under renal replacement therapy, but we are trying to build another registry with more patients now under dialysis treatments or transplantation. But I also have read that in the situation of chronic kidney disease, advanced stages of chronic kidney disease, there are some problems related with immunity that may do the virus to produce more problems in that situation when compared with patients without chronic kidney disease.
Yeah, absolutely. Ron, Christoph, do you have any comment to make about CKD 4-5 and how prevalent COVID is in these patients?
It's a difficult issue, and when we started our working group in our database, we discussed whether we should also include this group. But this is a very difficult group from a methodological perspective, because I think it's essential that you get a representative data set. And what threatens with, especially patients with CKD stage 4, that only the patients will be entered that have very worse outcome. And that's also what Emilio was referring to a couple of minutes ago, that when we are entering the data of our patients in our database, we should not only enter the patients that were admitted or died, but that should be really representative. So all patients that have COVID, whether they are admitted to hospital, yes or no, because only then we can really assess what the risk of these patients is and what risk factors for worse outcome will be. And for CKD 4 and 5, we discussed this, and many of them are living in the general population. We don't know whether they have COVID. That's different from our transplant patients and dialysis patients that are better managed by us. So we know them whether they have COVID, yes or no. And I hope that we there get a better representative sample.
What about testing in Europe? Are you having any issues with testing? Are you finding that your patients, so on renal replacement therapy, it's quite easy to get them a test if you suspect they have COVID?
Well, I think in many hospitals in the Netherlands there is a restrictive use of tests because there is a threatening shortage of the tests. So mostly people who have complaints and are sent home and not admitted are not tested for COVID. So the policy is that especially patients that are admitted and have complaints are tested.
And are you finding that there's a high false negative rate?
Yeah, well, we know that from the literature, the data of the false negative rate that can be 30%. So
I think in the UK, I think certainly in the early days, we would probably say that we'd found there to be a higher false negative rate than what's being quoted. I don't know if that's just our technique was less good, but probably in the region of 45 or 50% false negative.
If you use a PCR technique and you have trained personnel who is doing the test appropriately, then you decrease the rate of false dramatically. Yeah. So tested, trained people.
Yeah, so that, you certainly hear that from Hong Kong and Singapore, and the training the person to do the test seems to be very, very important.
It's not only a one-time test, because when the clinical picture is suggestive and you have got a negative test, we'll always do a second test. Yeah. And even when that is negative, we do a sputum PCR. And when you have that combination of tests, the rate of false negatives drops to very, very low percentages.
Okay, thank you. So we've got a question here from Prof. Brookfield again. So she's asking about the involvement of nephrology in the treatment of dialysis patients in intensive care. So how involved have nephrologists been with patients in intensive care, and what types of renal replacement therapy have you made use of? Do you have any comment, Prof. Sanchez?
At least in Spain, the involvement is not general in every hospital. There are different protocols, but in my opinion, I think that in intensive care units, the doctors from there do their best as they know to treat patients, and the nephrologists just do the renal replacement therapies when necessary, and also the doses of the drugs when do they know how to adjust doses to the condition of patients. I think that the main role in the treatment of these patients are made by doctors in intensive care units, but not by nephrologists in this case.
And do you know, are people having just sort of standard hemodialysis, or have they been getting diafiltration or SLED?
I have read and listened many things. Standard hemodialysis probably is the most common, but also slow therapies, slow long therapies are made in order to reduce inflammatory markers and things like that. So I think that in any hospital have their own protocols, and they do the better they know.
Yeah, absolutely.
So the nephrologist should come into place by telling all people that there is a substantial number of patients with high proteinuria and nephrotic syndrome. Those very severe have antithrombin loss across the urine and thromboembolism. And this becomes more and more clear. And if we promote urinary albumin testing in the severe cases, I think it would be quite helpful.
Yeah, absolutely. So this is not really a database related question, but it's to do with testing. So asymptomatic patients thought to be in the region of somewhere between 8 and 15%. Do you, as an expert panel, think that we should be checking antibodies, IgG and IgM? I suspect the answer to that is yes, if we got a good enough test, but please give us your opinion. So, Prof. Hilbrand.
Now,
I think that the information on the value of the antibody testing is currently just emerging. We are waiting the first reports about large series that have been tested. And I'm not quite aware at the moment what the clinical value of these antibody tests will be.
Will be, absolutely. We have one of our pediatric colleagues who is with us and is wondering, from the data that you've looked at just now, both the ERA-EDTA and Spain, are you seeing any sort of signal in the young adult population, so those 18 to 40? Are you seeing many of these cases? You may not have figures.
Unfortunately, sorry.
No, on you go. That's perfect.
Unfortunately, the disease is not affecting young people, at least here in Spain, where we have near 200,000 infected people. It's a disease of middle-aged and old men and women. And also the biggest problems are in older patients and patients with more comorbidity. No child or near no child, no young patients.
Yeah. So I think that's true in the United Kingdom as well. There's obviously the occasional case in younger people which makes the news and is sensationalized, but I think by and large we're finding, although obviously on a much smaller scale, similar. The Netherlands and Germany?
Yeah, the same.
Yeah.
And perhaps important to emphasize that our database is meant for adult patients, and there is a special pediatric registry that's done by ERCnet, the group of the ERA-EDTA involved with rare diseases, and there you can enter the data of children not only on dialysis or having a transplant, but also being treated with immunosuppressants. But also there the number of cases, like Emilio already alluded to, is relatively small to the numbers that we are seeing.
Yeah, perfect. So we're almost at the end of our hour. Does anybody have any final comment that they would like to make from our panel? Oh yeah, Prof. Hilbrand.
Yeah, I became aware that you maybe missed the last slides of my presentation.
Yeah, so you can, if you have them, you can show them or you can summarize them.
Yeah, maybe that's important because on the last slide some very important information is given.
No, that would be great.
I share my screen once again.
Yes.
And I will start here. These I think are very important messages that I want to give to you. So the ERACODA data set is a relatively large data set on kidney replacement therapy patients with representation from many European centers, and that's I think important because we are able in the future to compare the outcome between different countries and maybe within countries between centers. I think that the data will be sufficiently detailed for meaningful analysis of risk factors. An issue that I would like to mention is that it's fully driven by healthcare professionals. I noticed that there are some other databases in which commercial parties are involved. That's not the case in the ERA-EDTA data set. And as said, we have a unique patient identifier, the kidney transplant registry number or the Eurotransplant number, and that gives us the possibility for future connection with
Take care.
Bye-bye.
Bye.